Welcome back. So thank you for the good response for the previous video. So this will be about pathology, as you can see. So let me start the slideshow. Okay, so yes, slideshow. So this will be mainly focused on the slides. Okay, that is what you will be seeing under the microscope. So this will be helpful in case of picture-based questions that is going to be coming in the exam. And you might think it's easy, but we forget it. So I have my notes set with me and I'll be discussing along. So I'll try to cover as much as possible all the important ones. So firstly, we'll be looking at granulation tissue. So as we all know, what is granulation tissue? So I'll be discussing mainly only on the diagram. That is the pathological findings, that is the under the microscopy what you'll be seeing. So here, this is the granulation tissue. So here you'll have the cells. Then you can find the site of ulceration. And you'll find the lymphocyte, and also you'll be finding the macrophages. Macrophages are also found. Moving ahead, we'll also find the fibroblast. Series of fibroblasts can also be present. So in case of a picture-based question, you might be asked of any particular findings in the diagram and you should be able to recollect. For example, in case of Hashimoto thyroiditis, there's presence of hurdle cells. So the question can be framed in that particular manner. Like, which of the following has hurdle cells? So these are basics and we cannot make mistakes in them. So here we have almost done. So we can see this is a completely rough diagram. So it's just mainly to highlight what is present. So there's presence of fibroblast and also there's presence of neurovascular bundle. Just to highlight a few points. The outermost layer, it contains fibrin network with polymorphonuclear leukocytes also, and RBCs also. And deep to this zone of these capillaries, it is lined by a single layer of endothelial cells. And loosely arranged between the capillaries are fusiform fibroblast with abundant cytoplasm and nuclei which are central and elongated. So as mentioned here, the fibroblast, it is elongated and it has a central nuclei and the cytoplasm is abundant in this. And then amidst the fibroblast, there is a variable infiltration of inflammatory cells which are polymorphs, lymphocytes, plasma cells and a few eosinophils. So amongst this, you can also add other structures such as the lymphocytes that's already mentioned here. So lymphocytes and also the plasma cells and a few eosinophils as well. So assuming we already know how a granulation tissue looks, so talking only about microscopy, we have a place of ulceration that is found. We have many more cells such as the plasma cell, eosinophils, lymphocytes, macrophages as well, and a series of fibroblasts. So the character of the fibroblast, as I told, it's elongated. It has a central nuclei and it has a abundant cytoplasm. Okay, and there is also a neurovascular bundle. So as soon as granulation tissue is asked, you should recollect this diagram, that is a place of ulceration. So let this be a V. Okay, so granulation tissue, there's a V, that is nothing but indicative of lymphocytes. So here to the right and to the left you have a few cells. You can call it lymphocytes, macrophages, plasma cells, eosinophils. So you're covering all the cells that are present. And then there is presence of fibroblast, which is present. As I told earlier, I'm repeating again, it's a central nuclei, and cytoplasm is present on the side. And moving ahead, there is also a fibrovascular bundle. So now we are done with the granulation tissue. Now moving ahead, we'll be looking at how does in case of acute appendicitis, how does it look? So in case of acute appendicitis, just a second to make sure that I am still recording. Yes, I am recording. So I'll be continuing from current slide. Yes. So talking about acute appendicitis. So this is acute appendicitis. So in case of acute appendicitis, basically we need to know the main layers that will be visible. That is, we know the main layers, just a repetition. There is mucosa, and because it's under it, it's nothing but submucosa. And these are easy topics, and we should never ever think of making a mistake in these topics. So we have mucosa, and under it, it's easy, it is submucosa. Under this, there's nothing but muscularis externa, and under this, serosa. So these are the basic structures that needs to be present. So we'll be drawing the diagram again. So this is how it looks. We have a few cells here, and then you can also, the presence of necrotic exudates can be present. Necrotic exudates, or the necrotic material. And then, as we mentioned, muscularis externa. So in case of this muscularis externa, there's presence of circular as well as longitudinal muscles, as we all know. So drawing the circular muscles first. This is how the circular muscle looks. Okay. And then this is just a rough diagram to just mainly know what is present in the cell, so that we can recollect during our exam. So this is muscularis externa, and we have the longitudinal as well as the circular muscles that are present. Okay, hopefully it is clear. And in case there is also the neutrophil infiltration that is present. Neutrophils can also be present. Okay, fine. So we are done with this. Let's quickly recap what we have learned previously. So watching this video, I'll make sure that you have everything in mind. I'll frequently revise what I've already done, so that you don't have to again spend time to this. So as you finish this video, you will almost be thorough with multiple revisions, and it will be in your head. So I'll go back to granulation tissue, as we all told. So the more we repeat, it's easier to memorize. So that's what I'm doing. So granulation tissue is nothing but there's a V structure that is formed. That is nothing but we can remember it as the ulceration. So as I told, ulceration, it divides into two columns. So we can just name the few cells what we know. So it's easier to do it this way. So lymphocytes or macrophages, then you have eosinophils as well as plasma cells. So it's done. Okay. So I've told you it's lymphocytes, macrophages, plasma cells, and eosinophils. Okay. And then moving on, we'll be looking at the fibroblast, which is present in the bottom. So the fibroblast, as told earlier, they're like ovoid shape and they have a central nucleus with abundant cytoplasm, and there's also presence of neurovascular bundle. So this is done. Now moving on, we'll be looking at acute appendicitis. As I already mentioned earlier, we need to be knowing the basic layers of the acute appendicitis. That is the mucosa, submucosa, muscularis externa, and also the serosa. So 1, 2, 3, 4. So these are the important layers that needs to be memorized. And in case of the muscular externa, there is the circular muscles as well as the longitudinal muscles. So this is very easy to memorize. And also there's presence of infiltrating neutrophils that are present. That is also to be memorized. So looking at a few points, the acute appendicitis, the lumen is filled with acute inflammatory exudate. The mucous membrane is congested, necrosed, and also ulcerated. So the mucous membrane, as you see, there is congestion, there is necrosis, and also there's presence of ulceration. Okay, so it is easier to memorize. The same thing, like whatever we discussed here, there is ulceration. Even in case of acute appendicitis, there can be presence of ulceration. And also, to move ahead with the points, it is diffuse congestion and also polymorphonuclear cell infiltration of all layers of the appendix, and dilated and congested blood vessels in all layers. So there is presence of blood vessels also. So how do we draw? This is how we can draw the blood vessels. So blood vessels are also present, and it can be dilated as well as congested. So we are done with 2 topics. Just to give a brief about granulation tissue, as we know, there is a central ulceration, there is a few cells that can be drawn here, and then there's lymphocytes, there's plasma cells, there's macrophages, and also the eosinophils. And as told earlier, fibroblast has abundant cytoplasm and a central nuclei, and also there's presence of neurovascular bundle. Now moving ahead with acute appendicitis, there is a central ulceration, or there can also be presence of the necrosis that is found. And firstly, what needs to strike our mind is the layers. That is nothing but the mucosa, submucosa, muscularis externa, as well as the serosa. And we can also see the congested blood vessels that can be present. And the muscularis externa, as mentioned earlier, it's circular and longitudinal. Now, we are done with 2, and hopefully, I believe you have already memorized the 2 along with me. So now after this, moving ahead, we'll be looking at tubercular lymphadenitis. Okay, so what is this tubercular lymphadenitis? So in case of tubercular lymphadenitis, there's presence of a capsule. Yes, there is a capsule in case of tubercular lymphadenitis. So there can be a question being asked about which of these do not have a capsule, which of these have a capsule. So you need to be knowing all these. So then there can be presence of the giant cells. Okay, and there's also presence of epithelial cells. Okay, and along with them, there's presence of lymphocytes as well. So as we know in the previous what we have seen, we have also seen lymphocytes in the previous cases. So here also we have the presence of the lymphocyte. So we can call it the lymphocyte. And we can also see the giant cell. We can also see the epithelial cell. Okay, so this is done. And the capsule is present. So just looking at the points, there is note the structure of the lymph node. That will be the main point. And then many discrete and confluent tubercles consisting of epithelioid cells and giant cells are seen. So the main point is the presence of giant cells that can be seen, as well as the presence of epithelioid cells that can be seen. I repeat, the important point being presence of giant cell and epithelial cell, and this is in case of the tuberculoid lymphadenitis. Okay, then moving ahead, amorphous eosinophilic areas of necrosis are seen. Important. So areas of necrosis also seen. So let's repeat again. What have we seen? So this red, it's blood red, so it is easier to memorize. So I'm drawing it so dark so that it hits your eye. So it is nothing but a capsule that is present, and below that there is nothing but a giant cell that is present. So the main character is nothing but the presence of the giant cell as well as the epithelial cells. Now, looking at the points we have discussed, that is, there is also a presence of necrosis, areas of necrosis. Okay, done. Now quickly recapping what we have done just in few seconds. Ulceration tissue, macrophages, lymphocytes, plasma cells, eosinophils, and fibrovascular stalk as well as neurovascular bundle. Now looking at acute appendicitis, mucosa, submucosa, muscularis externa, serosa, as well as the muscularis externa is circular and longitudinal. And moving ahead, there is also presence of the congested blood vessels can also be present. And then moving ahead, the tubercular lymphadenitis, there is presence of the capsule, and also there's area of necrosis that is present, and there is presence of epithelioid cells and as well as the giant cells. This is important. Presence of the giant cells, that is very important. Now moving ahead, we have a lot to cover, so just stay along, and if you watch this video completely, it is going to be very helpful. And or in case if you can't sit for a long duration of time, you can do it in intervals so that it's easier for you. But I'm doing it in one stretch so that it's easier for me. Now moving ahead with, we just finished tubercular lymphadenitis. Now let's look at tuberculoid leprosy. That is the leprosy skin in case of the tuberculoid. So now moving ahead, there's nothing but the tuberculoid leprosy. So now what comes to your mind? The tubercular leprosy. So now there's presence of the thinned out epidermis. Yeah, normal or thinned out epidermis is present. So let's draw the epidermis. Okay. So there is usually presence of the eroded epidermis. So it can be thinned out as well as normal, as mentioned. Now the same thing in case of tuberculosis, we saw the epithelioid cells that are arranged in this fashion. So the similar thing continues here as well. Yes, so there is the epithelioid cells that are present. Okay, and then there's also presence of the Langerhans giant cells. Yes. So here as well we have seen the giant cells, that is in case of tuberculoid lymphadenitis, and here again we see the Langerhans giant cells that are present. And we can also add presence of the caches now, as well as the presence of the lymphocytes. Now just recapping what we have seen, we saw the eroded epidermis. We can see the epithelioid cells, presence of giant cells, and the caches now as well as the lymphocytes. Now just looking at some of the points, normal or thinned out epidermis is present, small foci of epithelioid cells with a zone of round cell infiltration around them with occasional Langerhans type of giant cells without cessation. Okay. And then infiltration of round cells around the nerve bundle. So there's presence of the epithelioid cell and also the Langerhans giant cell. These 2 points are very important. So in case of tuberculoid leprosy, we need to know this presence of Langerhans giant cell. They can ask the giant cell, the Langerhans giant cell is present in what type, which are the following. So we need to know this. So now moving ahead, we'll be looking at the fatty liver. So what is the fatty liver? So in case of the fatty liver, let's just draw a rough diagram. We can see the presence of the central vein, Yes, we can see the presence of central vein. And also there's presence of the fat cyst. There's presence of the macrovesicle. And as usual, the presence of the portal triad. So I'm assuming everyone knows what a portal triad is, so I'm not explaining it. Then moving ahead, let's look at some of the points. So in case of the fatty liver, the liver architecture is not disturbed. So this is a very important point. So in case of a true or false question, we need to know that it is not disturbed. Liver architecture is not disturbed in case of a fatty liver. And a large number of liver cells present vacuolated appearance. Okay, so a large number of these cells, that is hepatocytes, are present is vacuolated appearance. Okay, and then this is due to the fat which was present being dissolved out during staining process by xylol. Okay, and then next is it is most of the cell vacuoles are seen to fill cells completely and push the nucleus to one side. Okay, so what they are saying is, in case of a fat cell, we know that it's like a signet ring shaped, right? That's what we learned. So it's basically the fatty liver. I'll just summarize. So it's simple. The liver architecture is the same. It is not. It's not undisturbed. Okay. And there's presence of the fat cyst. There's presence of macrovesicle, microvesicle. Macro can be present. Microvesicle is present, and there's presence of portal triad. Okay. Portal triad is nothing but the artery, vein, and the bile duct that is present. Now this is done. Great. So now moving ahead, we'll be looking at something known as the hyaline degeneration. So we have it here. So this is nothing but the hyaline degeneration. Looking at the points, hyaline degeneration. Great. So this is nothing but the HD, hyaline degeneration. So firstly we have the hyaline change. So in case of hyaline degeneration, we can see the hyaline change. This is important. Then moving ahead, we have something called the Wold pattern, right? So in case you like these videos, I'll make more of them so that it's useful for all. So in case you like this, give a thumbs up or like so that I know that people are watching this and are interested. So then there's also presence of benign smooth muscles. Right? So hyaline degeneration is simple. We have the presence of benign smooth cells as well as you can draw the fibroblast. Right? So what can be seen in case of hyaline degeneration? So first thing that needs to be strike your mind is the hyaline change. What is surrounded by the hyaline change? You have the presence of the Wold pattern. It's like a Wold pattern. Okay. And this contains nothing but the benign smooth muscles. This is nothing but the smooth muscles. Right? Hopefully it's easier. So you have the presence of smooth muscles as well as the presence of the benign fibroblast. Right? So just doing a recap, there's presence of hyaline change, there's presence of fibroblast, there's presence of smooth muscles, and that is a whole pattern is seen. Yes. Now moving ahead, we'll be looking at the CVC spleen. So in case of the CVC spleen, there is also a presence of a capsule. So I want you to recollect, we just discussed a slide and we told one of them is capsulated. So which one is that? So let's just go back and see which one is capsulated. So it was tubercular lymphadenitis. Now just moving back, the same capsule, but here it's thickened. So let me just draw this. Thickened capsule. Yes. So just let me write the heading CVC spleen. So what is the CVC? It is nothing but the chronic venous congestion of the spleen. So this is nothing but the capsule. It is thickened, right? And then there's presence of the gamma Gandhi bodies, GGB. That is the gamma Gandhi bodies. So that can be an easy question. The presence of gamma Gandhi bodies are seen in case of, or they can give a very long history. In case the history is very long, the answer you can find it with a single word. Some questions they give irrelevant details to confuse. So you will have some keywords. So in case of gamma Gandhi bodies, it just refers to the CVC spleen. There can be a very big case history, and last statement would be there's presence of gamma Gandhi bodies in microscopy. So you can think of CVC spleen as a possibility. Now looking at, there are also congested sinusoids. One second. Now as told, congested sinusoids are present. So let me just recap what I told you. So there's a very thick capsule that is present. There's presence of gamma Gandhi bodies as told, the CVC spleen. There's presence of gamma Gandhi bodies, and there's also presence of congested sinusoids that are present. Now looking at CVC spleen, to note a few points. There's presence of dilated and congested sinusoids with increased amount of blood in the pulp. Okay. There's thickened connective tissue, trabeculae, and the walls of sinusoids. Fine. There's hemosiderin laden histiocytes in pulp tissues and sinusoids. Okay. And gamma Gandhi bodies that are nothing but fibrinolytic nodules with iron and calcium deposition may be occasionally seen. Okay. So these gamma Gandhi bodies, the explanation given is nothing but it is a fibrotic nodule, right? Nothing but a fibrotic nodule. So what is it composed of? Iron and calcium deposition. So we might neglect all this thinking it's short, but there are many easy questions that can be framed with this. So there's iron and calcium deposition that is seen. So we have already revised this. So I'll recap. CVC spleen, there's a very thick capsule. There's presence of gamma Gandhi bodies. Gamma Gandhi bodies is nothing but fibrotic nodules of iron and calcium deposition. There's also presence of congested sinusoids, as mentioned here. Congested sinusoids are present. So yeah, let's move ahead. So now we will be looking at the squamous papilloma. So as we know, why is it called squamous? It's finger-like. So let's call it squamous. Fine. So we know there are cells, and there are a few definitions which we need to go through. That is hyperkeratosis, yes, there's acanthosis, there's also papillomatosis. So these are some terms which we need to know what they are. So just memorize these terms. It's hyperkeratosis, acanthosis, as well as papillomatosis. Fine. And there's also absence of vacuolated cells. Now just moving ahead with the points we can find under the squamous papilloma. The papillary, that is the finger-like proliferation of squamous epithelium of the epidermis with intact basement membrane of basal cells. So there's intact basement membrane that is found. Membrane. and looking at the central vascular connective tissue core with a sprinkling of round cells. There's sprinkling of round cell as well. Now just going through it again, there's presence of hyperkeratosis. So these characters are nothing but, they are the method how it proliferates and the features that are seen within these cells. So there's hyperkeratosis, acanthosis, as well as papillomatosis. Fine. Now moving ahead, we'll be looking at the squamous cell carcinoma. So I have not written the name here, so it is nothing but squamous papilloma. Now we'll be looking at nothing but the squamous cell carcinoma. So the very important point here is, okay, so we can just draw cells and there is downward proliferation of cells. Okay, so there's nothing but here there is downward proliferation of cell. So that is what we are seeing here, there is downward proliferation. Now looking at the keratin pulse, this is nothing but the keratin pulse. Okay, so there's malignant tumor cells, malignant squamous cells, okay, are present along with the keratin pulse. So very important point, in case of squamous cell carcinoma is nothing but the presence of the keratin pulse. So here we have the keratin pulse, right? So there's presence of malignant squamous cells, there's presence of keratin pulse, as well as there is downward proliferation that can be seen. I'll be doing a 2 more and I'll be recapping the entire thing from the start so that it's very easier and you don't have to look back at it anymore, so that you can recollect it and it's very easier for you. So now looking at the fibroadenoma. So what is this fibroadenoma? So the fibroadenoma is in the breast, which is related to the breast, and there are 2 types, that is pericanalicular as well as the intracanalicular. Now just looking at the intracanalicular, so to make it easier I'll draw it side by side so that it's very easy to see. So there's intracanalicular, so this is nothing but the intracanalicular and this is nothing but the pericanalicular. Okay, done. So what is pericanalicular? So pericanalicular, you can, it will be a ring like structure with a nucleus here. Fine. Now there is nothing but the collagenic stroma that can be seen. Hopefully we know what a stroma is. Yes, collagenic stroma is seen, and also the patent duct can be seen. This is pericanalicular. So as you know, there is something like a ring like structure, right? So in case of intracanalicular, there is presence of a compressed duct. Yes, there is nothing but a compressed duct that is found. Yes, and as usual there is presence of collagenic stroma. So in case of pericanalicular, it's peri, so you can think of periphery and there's a ring like structure, whereas in case of intracanalicular there's nothing but a compressed duct. That is it. So now just highlighting a few points. There's fibroadenoma of breast is 2 types, that is pericanalicular and intracanalicular. Now looking at the intracanalicular, there's a fibrous capsule with blood vessels. Okay, these are some additional points. This fibrous capsule with blood vessel. Okay, so this fibrous capsule with blood vessels as well, and there's distended acini with cuboidal epithelium and intact basement membrane. Okay, there's proliferation of new fibrous tissue around the ducts and acini, specifically around the distended acini. Irregular foci of proliferating new fibrous tissue invaginating the acini or the duct lumen, giving them a tortuous, wavy, slit-like appearance. So this is nothing but the intracanalicular type. So what is happening is that there's proliferation of new fibrous tissue. So this is nothing but it's giving it a wavy, slit-like appearance. So this wavy, slit-like appearance is nothing but for the intracanalicular. So it's clearly described as a wavy slit-like appearance that is nothing but the intracanalicular type. Whereas pericanalicular, it is simple. There's a new fibrous tissue around the ducts and acini, and specifically there's around the distended acini. Okay, so this is done. So it's easy. Now the easiest, which all of us love identifying, that is nothing but the lipoma. Lipoma is very easy to see under the microscope. So lipoma will be, it will look very dark and look like a mesh, exactly like a mesh. Okay, so this is nothing but mature adipocytes, right? So this is nothing but mature adipocytes, right? And there's presence of the capsule. Okay, so just looking at the diagram is just simple. You just have a capsule. I have mentioned it twice so that you remember it again, and also mature adipocytes. Now just after this I'll be looking at few points, that is fibrous capsule with septa containing blood vessels, masses of proliferating fat cells separated from one another by fibrous septa underlying the capsule. Okay, so we can tell that there's presence of fibrous septa as well. So that is an additional point. And there is vessels, okay, with capsules. You can find vessels as well, blood vessels. So just to recap, there can be presence of fibrous septa, there's presence of a capsule, there's presence of mature adipocytes. Adipocytes, we know its nucleus is pushed to the side, so it's easier. It's very easy to identify the lipoma. And next, moving on, we'll be looking at the neurofibroma. So these things are very simple and very easy. So I'll go a bit fast, I'll accelerate. So there's neurofibroma, and in the neurofibroma there's presence of the nerve fiber. So what is this? The nerve fiber, right? So I think I've gone a bit fast in the past 2-3 slides, so I'll don't worry, I will be recapping that. So there's nerve fiber, there is also the fibroblast. So in case you're watching this complete video, it is basically a recap of all the important diagrams, which will be very easy in case it's asked. We can easily recollect. So there is the presence of the nerve fiber, there's presence of the mescoid matrix, as well as the fibroblast, right? So just looking at a few points, the neurofibroma is nothing but interlacing fibrous tissue and nerve bundles. It is interlacing, okay? And there's deposition of foam cells. So you can also see presence of foam cells, right? So neurofibroma has presence of foam cells and also pigmentation. And the nuclei of the tumor cells are oval to spindle shaped, uniform size, pale staining occasionally, and the nuclei lie in parallel rows. Okay, so what we have seen is the nuclei of the tumor cells are oval to spindle shaped, fine, and they are uniform size and pale staining occasionally, and nuclei lie in parallel rows. Okay, now just recapping what we have done, we have gone a bit fast, so I would say let's do it from tuberculoid leprosy. So in case of tuberculoid leprosy, we had seen that there's presence of Langerhans giant cells. So the type of giant cell is nothing but the Langerhans giant cells. There's presence of caseous nerve, there's presence of lymphocytes as well. So I'll just draw a T here so that it's just easy to recollect. So in case you see this, you can memorize there's a T, tuberculoid leprosy, right? So it's easier to memorize. So there's a T here. So in case I tell tuberculoid leprosy, your mind will be, it'll go back to this T here. So first you'll recollect the T and then you'll recollect the O on top. So the T is nothing but the, what is it? It is presence of the caseous nerve. There's also presence of Langerhans giant cells, Okay, tuberculoid, this L is nothing but, and leprosy, it's nothing but for Langerhans giant cells. So you have two L's, stands for Langerhans giant cells. Done. That is an important point. And also presence of epithelioid cells, which can be seen, and also the eroded epidermis. Moving ahead, looking at the fatty liver, as mentioned, there's presence of the macrovesicle, microvesicle, central vein, portal triad, that is the artery vein and the bile duct, and there's also presence of the fat cells, and as we know, the nucleus is pushed to the side. So moving ahead, the hyaline degeneration, as mentioned earlier, with the hyaline degeneration, we need to be knowing what is the hyaline change, and we have drawn what is the hyaline change here. So this is the hyaline change. There's presence of there's a whole pattern of cells. This is nothing but the epithelioid, right? There's presence of the smooth muscles, cells that are present, and also this presence of the fibroblast. Okay, and these are the smooth muscles that can also be present. Now moving ahead, we have the CVC spleen. So what is the CVC spleen? There's presence of capsule, as mentioned earlier, as well as presence of gamma antibodies is present occasionally. And what is this gamma antibodies? It is nothing but a fibrotic nodule with the presence of gamma antibodies. So it has presence of iron, calcium deposition. Okay, and that is it. So there's a congested sinusoid as well. And looking at the squamous papilloma, here there are three terms which need to be memorized, and it's good that we go back and recollect these definitions as well. So learn what is hyperkeratosis, learn what is acanthosis, as well as learn what is papillomatosis. So these are the three properties that are seen in these cells. So there's hyperkeratosis, acanthosis, and papillomatosis. This is in case of the squamous papilloma. Okay. So there is also presence of the intact basement membrane, as we read theoretically. So here the squamous cell carcinoma we have been studying. So the squamous cell carcinoma, there is nothing but a downward proliferation that can be seen. There's presence of keratin pulse. So in case of squamous cell carcinoma, so there's carcinoma, so there has to be carcinomatic cells. So here is you have malignant squamous cell carcinoma cells, yeah, malignant cells, and there's also presence of keratin pulse that are present. Moving ahead, there's presence of fibroadenoma, right? So what is this fibroadenoma? We have learned what is fibroadenoma. It is concerned with the breast, and there are two types, that is pericanalicular as well as the intracanalicular fibroadenoma. Now looking at the pericanalicular, there is it's duct shaped, okay, and there's presence of collagenic stroma, whereas here in intracanalicular, we have learned that there's a wavy pattern which is nothing but a slit-like appearance, and there's presence of collagenic stroma. Yes, and there's also presence of fibrous capsule and presence of blood vessels, right? So now moving ahead, we have seen the lipoma, which is a very easy structure to be seen under microscope. So there's mature adipocytes and there's presence of capsule. There's also blood vessels that can be found. And looking at neurofibroma, as the name suggests, there's neurons. So there's nerve fibers that are present. There's interlacing fibrous tissue and the nerve bundles, and deposition of foam cells and pigmentation. So just a rough diagram, this is nothing but the foam cell. So the foam cell is also present, FOAM, right? The foam cell is also present. Okay. So there's presence of nerve fiber, there's presence of foam cells, there's presence of the fibroblast as well as the mescoid matrix. Fine. Now moving ahead, we'll be looking at something known as the capillary hemangioma. What is capillary hemangioma? So now looking at the diagram of how this looks, so there's nothing but a plump endothelium, right? So firstly, let's draw the plump endothelium. Plump endothelium is present in case of the capillary hemangioma, and this presence of, as usual, this presence of normal skin. There's normal skin as well as the presence of plump endothelium. Yes. Now moving ahead, looking at a few points, the numerous small uniform blood capillaries with lumen lined by plump oval endothelial cells loosely supported by connective tissue stroma. So again, as usual, you can just add a stroma in almost everything. So there's a plump endothelium, they have mentioned that, and then group and sheets of proliferated endothelial cells. Okay, and then there is no inflammatory reaction. This is an important point to be noted, that there is no inflammatory reaction in case of the capillary hemangioma. No inflammatory reaction. Now just going back to what we have read again, there is the normal skin that can be found, and there's also the presence of the plump endothelium, and also there's no inflammatory reaction, and there's presence of the stroma. Great. So hopefully you are along with me, and looking at the next one, we'll be looking at the cavernous hemangioma. So what we saw before is nothing but the capillary hemangioma of the skin, and now we'll be looking at the cavernous hemangioma. What is the cavernous hemangioma? So now we'll be seeing what it is. So here we have nothing but a flattened endothelium, right? Hopefully it looks flat. Yes, it does. So there's nothing but the flattened endothelium, right? So this is nothing but, if that is a flattened endothelium, what is the space in between? It is nothing but the cavernous space. So in case of cavernous, just remember the word cave. So there's emptiness. So there's a space here that is nothing but cave. So you write cave and then you remember ness, cavernous. So there's nothing but cavernous, and there's presence of flattened endothelial cells that are present in the outer region. So there's nothing but the flattened endothelium. And looking at there's also presence of the normal liver tissue that can also be seen along with the structure. Presence of normal liver tissue that can also be seen, right? So now just recapping few points. I mean, we'll look at the few points. That is subcutaneous cavernous hemangioma. There's a structure of the skin. There's irregular, large, blood-filled spaces with a single layer of endothelial cells and thick fibromuscular wall. Okay, and there is also dilated blood vessels filled with blood and areas of hemorrhage. Okay, and there's also dense and loose fibrostoma. So there can be presence of dense as well as loose fibrostoma, but the main point here to memorize is there is a flattened endothelium, there's presence of cavernous space, and as well as normal liver tissue can also be seen under the microscope. Liver tissue can also be seen. Next, we'll be looking at what is known as the schwannoma, right? So I'm looking at the diagram of schwannoma. There is presence of antennae A and B particles, right? So the outer region is nothing but the antennae B particle, and the inner, it contains the antennae A particle, right? Pattern. And this is nothing but the antennae B pattern, right? And this is nothing but the palisaded nuclei, nothing but Verroque bodies are seen. So main important thing is in case of schwannoma, they can ask which of these structures are not present in case of schwannoma, and they can give antennae B, antennae A, and whatever is there, and whatever is not included, that will be the answer. So there can be multiple ways the question is framed. So schwannoma, it contains antennae A as well as B. So here A always comes to the center. Fine. A. So just remember there's a ball, so it's written A. Fine. So always remember this ball with an A, so you'll never forget. So I just drew a ball with an alphabet A. So just remember the antennae A particle comes towards the inner side, and the antennae B particle, it comes to the outer side. So it's B. So you can remember it this way. I'm drawing B-like structures. Okay, the B comes outside and the A comes inside, right? And there's presence of palisaded nuclei. nuclei, also known as the Verroque bodies, right? Now moving ahead, we will also be looking at the basal cell carcinoma. Now looking at the basal cell carcinoma, it is also known as the rodent ulcer, as we know that it looks like a skin or the tissue that is infected by a rodent in case of a bite. So it looks similar to that, that's why it's known as the rodent ulcer. So it's very important to know this keyword. So in case of basal cell carcinoma, the first word should strike is it's nothing but the rodent ulcer. So looking at the diagram here, just drawing the cells, there's also presence of tumor cells mainly. There's tumor cells arranged in solid pattern, and there's also presence of palisade arrangement. This is a small topic, that's basal cell carcinoma. That is presence of tumor cells, you have solid pattern, as well as there's presence of it in palisade arrangement. Now looking at a few points, there are basal cell carcinoma, group and masses of darkly stained small epithelial cells with prominent nuclei and scanty cytoplasm invading the dermis from the basal layer of the epidermis. Fan-like radiating arrangement of the peripheral layer of cells of the epithelial masses. So there's fan-like radiating arrangement of peripheral cells. Fan-like radiating arrangement. And there's absence of epithelial pulse, also known as horn pulse. Absence of epithelial pulse. This is important. So there's absence of epithelial pulse, also known as horn pulse. So now moving ahead, we have seen basal cell carcinoma. Moving ahead, we'll be looking at what is known as the adenocarcinoma. This is also very simple. So we have a group of cells here, and there's presence of the malignant cell, and there's presence of a pool of mucin, right? So in case you're watching this video, I'm pretty sure that by the end of this video, I'll make sure I try my best to help you memorize and recollect what we have learned before already. So now looking at the adenocarcinoma, we'll be looking at few points. That is nothing but the presence of malignant tumor cells as well as pool of mucin. And moving ahead, just giving a few points of adenocarcinoma. In case of adenocarcinoma, there is proliferating glandular acini lined by darkly stained columnar cells in one or many layers, showing anisocytosis, anisonucleosis, and mitosis. So moving ahead, the break in continuity of the basement membrane with infiltration of stroma by malignant epithelial cells, as mentioned, and there's also many cells are distended with much of the nuclei pushed to one side like large signet ring. So it's common, there's like signet ring like structures, and at places the pools of mucin material are seen with tumor cells appear to be floating. So in case of adenocarcinoma colon, just remember that there's presence of signet ring cells, malignant cells, and pool of mucin. Now moving ahead, we'll be looking at the metastatic, or we'll be looking at the metastatic carcinoma of the lymph node. The structure is simple. So firstly, we have the capsule. So the lymph node, yes, we have the capsule. Yes, this is nothing but the capsule. And then looking at the capsule, we also have the sinus that is here. You can call it the scapular capsular sinus, subcapsular sinus. Okay, and then there's also presence of malignant cells that can be seen. Cells that can also be seen, and also the presence of the lymph node, LN. So there's presence of the lymph node that can also be present. So going ahead, there's nothing but the malignant cells, there's subcapsular sinus, as well as the lymph nodes that are present. Okay. So now moving ahead, we have to finish a lot more. So if you just hold on, we can finish it. So next is benign cystic teratoma ovary. So it's nothing but the teratoma ovary. So in case of the teratoma ovary, what are the structures present? So we can just look at, in the side we have the stratified squamous lining. So I'll be telling it again, it is nothing but the stratified squamous lining, right? And then there's also presence of cartilage. You can draw the cartilage, hyaline cartilage. So there's presence of cartilage, there's presence of smooth muscles, yes, wait, this will be confusing, right? Okay, I'll be okay, right, it's easier. So this is nothing but the smooth muscle, right? This is the smooth muscle, that is the cartilage. And then we also have presence of the gland. This is nothing but the gland, and this is nothing but the adipocytes. So just recap what is there in teratoma ovary. So firstly, we had the stratified squamous lining, and then we also had the presence of the cartilage. This is nothing but the cartilage, and also there's presence of the smooth muscles. So I have drawn the cartilage, and surrounding it I have drawn some structure. So you need to memorize that it's nothing but the smooth muscles. So there's cartilage which I have drawn. So just recapping what I have done, left side I have just drawn the stratified squamous. Towards the right, this is just to help in memorizing. So you have the cartilage, surrounding it nothing but the smooth muscles, and also bottom I have also drawn the adipocytes, and there are presence of glands as well. So adipocytes, above adipocytes there are glands, right? So there are glands here, surrounding it there's adipocytes. Here there are cartilage, surrounding it there's stratified squamous epithelium, squamous lining. Here there's stratified squamous lining, and here this is nothing but the smooth muscle. Okay, the smooth muscle. Fine. And just looking at a few points, the element of the ectoderm in the teratoma, the elements of the ectoderm, the skin layer with appendages, brain tissue, etc., and the elements of the endoderm, granulation tissue of the intestine, thyroid, or any derivative of the gut. Elements of the mesoderm, nothing but the muscle tissue, bone, cartilage, adipose tissue, and other connective tissues. This is in case of teratoma. So this is nothing but the benign cystic teratoma. So the important point here is nothing but presence of the cartilage. The adipocytes can also be present. There's presence of the glands. There's presence of stratified squamous lining, that is important. There's also the columnar linings that are seen. Okay, there can be columnar lining as well. So columnar lining. So now moving ahead, we have seen this. Now we'll be looking at what else is there. There are many. So we'll be looking at athiroma. So what is athiroma? Common site is I'll give you a second to guess. Yes, it is the aorta. So we'll be looking at athiroma of the aorta. Fine. So here it's easy. So let's just draw a layer of cells. Fine. And below that we can have a few nice cells. We can have the foam cells and also the plasma cells. Wait, is there a plasma cell? Yes, there is a plasma cell. So you can tell there's foam cell, there's plasma cell, there are something cell. So there's foam cell, plasma cell. There's also the presence of the lymphocyte. So this is nothing but the lymphocyte. Fine. And looking at the media, there is there's nothing but the media. And here there's nothing but the thin media. There's nothing but the thin media. And there is also the adventitia. There's presence of necrotic debris. So in case of athiromas, there are a lot of things going by in the cell level. So these are the structures. So just repeating, there's presence of lymphocytes. This is nothing but the lymphocyte. Fine. There's presence of the plasma cell. There's presence of necrotic debris. There's presence of foam cells. Okay. There's presence of disturbed lamina. Now it might sound very it might sound difficult, but I'll just make it simple. So yes, I'll just take this much space to explain the entire thing in a simple fashion. So we have seen this what is this? Okay, something is going down diagonal. So what is this thing going diagonal? So this is athiroma. So this is nothing but the proliferating smooth muscle. Yes, smooth muscle, right? So what did I just draw in the starting? From diagonally, this is nothing but the proliferating smooth muscle. So looking on the cell, I told you there are dash cells, dash cell and dash cell. So it's nothing but the foam and plasma cell, PF. Foam and plasma cell, right? So it is done. It's easier to memorize. And you can also add some lymphocytes as well. So lymphocytes can also be present. Now moving ahead, there is also the necrotic debris that is found. Yeah, so this is easier. So just remember a mountain. Above that there are some structures that are present. So this is nothing but the elastic lamina that is present, and above that it is nothing but the necrotic debris. This is nothing but the necrotic debris. This is nothing but elastic lamina. And here in the bottom it's nothing but the adventitia. This is nothing but the adventitia, right? So are you with me? Hopefully the answer is yes. And I think I've complicated it, so I'll just make it simple. So in case of something tough, we have to go a bit slow so that we can retain it for a longer duration of time. So now I have told there is proliferating smooth muscles. Yeah, smooth muscle cell. Fine. So I have told two cells are there. That is, you can call it the foam cell, as well as there's presence of the plasma cell. It's easier. So now there's also presence of, I have drawn this, right, the mountain. So this mountain is nothing but the elastic lamina, disturbed elastic lamina. And this is nothing but the, what is this? This is nothing but the necrotic debris. So we're just doing it in pairs so that it's easier. Smooth proliferating cells, two cells, plasma and the foam cell. Then there is a mountain, that is a necrotic and the elastic disturbed lamina. And you can tell the thin media layer, and then the adventitia layer is present, right? So now we have done this. So let's just look at some points. That is athiroma of the aorta in specific. There's a well-developed atheromatous plaque bulging into the lumen of the aorta, and there is deeper in the atheromatous plaque. The deeper the atheromatous plaque, the fibrous tissue has lost all its structure and is swollen, and the hyalinized and fragmentized, and a few empty elongated needle-like spaces suggesting the cholesterol crystals are present. The adventitial coat and the vasa vasorum are normal. So here, important point is what is normal. Nothing but the adventitial coat as well as the vasa vasorum. Vasorum is normal. Yeah, I repeat, what was normal? The adventitia coat as well as the vasa vasorum is normal, right? Now moving ahead, we'll be looking at a famous one, that is nothing but the gastric ulcer. So when you're looking at these, you should also just refresh on the pharmacology. So you know the drugs used in ulcers. Yes, so ulcer protectives, anti-H. pylori drugs, yes, and H2 blockers. So when you do a subject, it's obvious, it's very easy. in case you relate the subjects, and side by side you can do multiple as well, multiple subjects. So revision becomes very easy. So in case I'm studying gastric ulcer, I would take a book of pharmacology and just revise the drugs used in case of the peptic ulcer. So it's very easier to just combine the subjects and do it easy as we do it along. Now looking at the gastric layer, so all the layers of the intestine, as we know, it has this pattern. So now we have the intact mucosa. We'll just lower some cells, and then we have the intact mucosa. Okay, and then there's presence of the necrosis that is present. This is nothing but the necrosis. Now there's also presence of the granulation zone. Okay, so gastric ulcer, so the G and G, right? There are two zones, that is granulation zone as well as zone of cicatrization, right? So this is known as the zone of cicatrization, and this is known as the granulation zone. Fine. Now just recapping the structures we just drew. So it is nothing but it has an intact mucosa, there's presence of the necrosis, there's presence of the granulation zone, there is also the presence of the zone of cicatrization. So now just reading a few points, it is there is the floor of the ulcer consists of 4 zones. Okay, there's a superficial zone. It consists of tissue debris in which are seen are polymorphs, lymphocytes, and a few RBCs and fibrin. So there are polymorphs, lymphocytes, there are a few RBCs, and also presence of fibrin. So come on, let's repeat. There's presence of fibrin, there's presence of there's presence of RBC, there's presence of lymphocytes. Okay, so beneath this zone, there's a zone of the necrotic granulation tissue. Fine. And beneath this, there's a broad zone of healthy granulation tissue, and below there is fully formed fibrous zone, fibrous tissue. So let's just recap what is seen. So there's something called a superficial zone. So the superficial zone is nothing but contains all these cells. That's RBC, fibrin, RBC, there's fibrin as well. Okay, so this is nothing but a zone of superficial zone. Beneath this, there's a necrotic granulation zone. Below this, there's a broad zone of healthy granulation tissue. Okay, so there is a necrotic granulation zone. So if you see, the granulation zone is divided into 2, right? So what are those? First one is nothing but there's some necrosis, and next one there's almost normal, right? There's healthy. So firstly there's NN. So firstly there's necrosis that is seen, then there's normal tissue that is seen. Then below there is nothing but a fully formed fibrous tissue. Okay, and here there's nothing but the zone of cicatrization. Now moving ahead, another favorite topic, that is nothing but the cirrhosis of the liver. Just looking at how much we have, we just have few and we can finish it. And it's always good to do it in a single sitting so that it's easier. So now looking at the cirrhosis of liver. So I've started and this is going non-stop. So this is the cirrhosis of liver. So cirrhosis of liver, so mainly you can draw the uniformed micronodules. Okay, uniform micronodules, right? And then you can call the fibrous septa, right? Fibrous septa. Okay, and then there's also presence of the ductal proliferation, right? And you can also see the fatty change. So I know that the diagram, I'll repeat it. So just have a look. Right? So now I'll be showing the fatty change, right? And then there's also uniform micronodules that are present. Okay, this is nothing but the uniform micronodules, correct, micronodules. And then there's presence of fibrous septa, ductal proliferation as well. There's ductal proliferation and fibrous septa. Okay, so now just recapping what we have done, we have shown a fatty change. There's also uniform size micronodules. So there's a fatty change here, means there are uniform cells, nothing but uniform micronodules, right? And then there's also presence of the fibrous septa as well as ductal proliferation. Done. Now just looking at some theoretical knowledge, the portal cirrhosis of liver. There's normal architecture of the liver is distorted by bands of fibrous tissue. Okay, so there's bands of fibrous tissue, so the normal architecture of the liver is disturbed. So whereas in fatty liver we have seen that it is not disturbed. Yes, so while doing a topic we need to make sure that there are some divisions and we often relate to them so that it's easier to memorize. So here the normal architecture of liver is distorted. So distortion, right? And then moving ahead, it is seen in bands of variable breadth intersecting the liver tissues into several islands or nodules. So you can see there are some islands. So there are some bands and these bands are dividing it into islands. So we can see here it is nothing but almost an island. So the island are variable in size. The normal architecture of the lobule is lost. The advanced fatty degeneration is seen in liver cells. Now looking at the next point, the fibrosis is replacement in character. It in other places it resembles the granulation tissue, being vesicular, fibroblastic and irregularly infiltrated with round cells. Okay, so what we have seen is they have formed some particular island like structures, right? There are bands which intersect the liver and making them into several islands or nodules, and there's presence of fatty change and there's presence of uniform micronodules, right? Hopefully you're with me. Now moving ahead, we'll be looking at something known as the renal cell carcinoma. In case you're finding it difficult to cope up with the time, I would suggest you watch it in segments so that it's easier for you as well in case you're busy doing something else. So but make sure you cover all of them because all of them are important and can be asked in various MCQs as well. So here I'll be drawing the renal cell carcinoma. To make it easy, I'm just drawing an R. Okay, so here you have clear cells. This is nothing but clear cell. So you have glands. So there's glandular pattern. There's also a solid pattern that is seen. There's also uniform tubular cells that are seen. Tubular cells. And there's presence of compressed residual renal parenchyma. So there's compressed residual renal parenchyma. Now just repeating what I have just spoken. So there is presence of clear cells. And the patterns, you can see solid pattern, you can see glandular pattern, and there are presence of uniform tubular cells. Okay, uniform tubular cells are seen, and there's also presence of compressed residual renal parenchyma. Okay, now just looking at the renal cell carcinoma RCC, looking at a few points. The renal architecture, note the renal architecture at one end. Yes, there are the compressed residual renal parenchyma that are seen. So next, the tumor cells are arranged in alveolar structure. In some parts, as papillary processes projecting into cyst-like spaces at the other parts. So in some parts, as papillary processes projecting into cyst-like spaces at the other parts, okay, and the cells are large, polyhedral or cuboidal or columnar, and the nuclei are small, are deeply stained, cytoplasm clear and vacuolated due to lipid, glycogen and hydrophic degeneration. I repeat, the nuclei are small and deeply stained. So the nuclei are small and deeply stained, and the cytoplasm is clear. Yeah, so you have the clear cells. So the cytoplasm is clear and vacuolated due to the lipid, glycogen and hydrophic degeneration, and it appears vacuolated, and this is due to nothing but the lipid, glycogen and the hydrophic degeneration. Yes, and hemorrhages and necrosis can also be seen, right? So just recap, what is renal cell carcinoma? I drew an R, right? So this presence of clear cells, the C, one of the C's, refers to nothing but the clear cell. So it's nothing but this presence of the clear cell, right? Yes. So this presence of the clear cells, and this glandular pattern can be seen, solid pattern can be seen. So there's uniform tubular cells that can be seen, and this compressed residual renal parenchyma that can also be seen. Okay. Now we have also, there is also presence of hemorrhages, right? Presence of hemorrhages, and there's also presence of necrosis, right? As well as necrosis. Now moving ahead, we will be looking at the secretory endothelium. Yes, so how many do we have? We just have a few more and we will finish it as well. So we just have a few more, and thank you for staying along so far. So now looking at the secretory endothelium. Yes, secretory endothelium is, you have the tortuous glands. Okay, so there's nothing but the tortuous glands. Okay, and it's lined by glandular epithelium, right? Okay, and there's also the stroma as usual, some cells here. So there's stroma. Okay, tortuous glands, as I drew, the structure is not perfect. It's a tortuous gland with lined by glandular epithelium. Okay, so this is nothing but the secretory endometrium. So now just looking at the points, the surface epithelium is cuboidal or columnar. So the surface epithelium is cuboidal or columnar, right? Next, the glands are hypertrophic with gradual widening of the lumen and steadily increasing convolution. And next, the early phase, there is not much of secretory activities of the glands, but later the secretory activity fills the lumen with eosin stained secretion. Okay, so what they're telling is, in the early phase there's not much of secretory activity of the glands. So early phase there's not much of activity, whereas the late phase there's so much of activity. Yes, there is some activity. So the eosin stained secretions can be seen. Eosin filled secretion can be noted here. Okay, now moving ahead, at this stage some glycogen granules are seen in cells. Yes, okay, so some glycogen granules can also be seen here in these cells, right? So now moving ahead, the stroma is not so dense, that is edematous, and there are a large number of capillary blood vessels with occasional hemorrhages. So here we notice that hemorrhages, necrosis are almost common in everything. So here you have the hemorrhages can also be seen. There's tortuous glands, and we know that the surface epithelium can be cuboidal as well as columnar. That was one point we saw. And there's also the another point which we saw was that in case of early phase, there's not much of activity that can be seen, whereas in case of the secretory activity, in case later, the secretory activity fills the lumen with the eosinophil filled secretion. So later there's a eosinophil filled secretion that can be seen. Great. So now wait, did I just, one second, let me add more slides. Yes, let's add more slides. So how do we add? Insert, new slide. Great. So now going back, yeah, 27, right? Okay, great. We are just in a good shape now. So looking at, where is the animation? Wait, insert, videos, dot design, slideshow. Yes, start from current. Yes. So now we are back, and we'll be looking at the cyst adenoma ovary, right? So here there's nothing but the cyst adenoma ovary. This is a topic we'll be discussing, and in the cyst adenoma ovary there are two types. There is the mucinous as well as there is serous, right? So what is it? Mucinous as well as serous. So now looking at the diagram here, I'll be drawing it side by side. Yeah, so this is nothing but the ciliated columnar epithelium, right? And this is nothing but the fibrous stroma with fibrous. This is nothing but the fibrous stroma with collagen fibers. Done. Here it's nothing but the columnar cells. Here it's nothing but the, let me draw a few cells. Yes, this is nothing but the fibrous stroma. And here it is nothing but the mucinous material. Right? So just looking at the points individually, firstly I'll be looking at the mucinous cyst adenoma ovary. So it consists of a honeycomb of glandular structure. So here, as you see, you can draw some, so it looks like a honeycomb, right? You have a lobes kind of structures, right? So it looks like consists of a honeycomb of glandular structure, and they are formed, they are round, oval, elongated and irregular, right? So they are round, oval, elongated as well as irregular, right? Next, most of them are lined by a single layer of tall columnar epithelioid cells, while rarely they undergo cystic dilation lined by flattened epithelia. So we can tell that columnar cells are most common, right? Yes. Next, moving on, most of the columnar cells are filled with mucoid secretion, faintly acidophilic goblet cell type. The nucleus at the cell base. So these columnar cells are mainly filled by mucoid secretion. So this mucoid secretion. Columnar cells are filled by mucoid secretion. So this mucoid secretion, the columnar cells, right? Next, the honeycomb framework consists of cellular fibrous tissue in which a few vessels are seen. Cellular fibrous tissue in which few vessels are seen. Fine. The septa in some places are reduced to thin partitions by dilation of the cystic spaces. So the septa in some places are reduced to thin partitions and dilation of the cystic places. So here I can tell you some important points. That is nothing but this presence of columnar epithelium, right? And there's presence of fibrous stroma, right? And there's presence of the mucinous material. So let me just take this much space to just summarize what we have learned. So this columnar, right? Are you with me? This fibrous septa, yes. And there's mucinous material, yes. So these are the important points: columnar, fibrous septa and mucinous material. Same thing when we compare with the serous type. Serous type, there is numerous cystic spaces of various sizes are seen. Okay, fine. And then the cystic spaces are lined by tall columnar ciliated epithelial cells. So there are tall columnar ciliated. So this diagram, I hopefully you remember. So this, yes, there are tall columnar ciliated epithelium, and the epithelial cells have granular pink cytoplasm and central vesicular nuclei. Yes, the epithelial cells have granular pink cytoplasm and central vesicular nuclei. Fine. Now moving ahead, just recapping again. So in case of mucinous cystadenoma, I think I'll draw it again so that it's easier. So there's a mucinous cyst adenoma, and this is of ovary. And next we will be looking at serous cyst adenoma ovary. Fine. So here there's nothing but the columnar epithelium that is seen. So there's a columnar epithelium, and then there's a fibrous stroma that is also seen. This is nothing but fibrous stroma, right? And then here there is mucinous material. Mucinous material. Yes, so hopefully this is much better than this. Yes, I made it simple. So you can see columnar epithelium in the center. There are cells, they're running. So there's nothing but the fibrous stroma, and then there's mucinous material, right? Mucinous material. Fine. It's simple and easier diagram. And here what you're seeing is there are tall columnar cells. Fine. And they are ciliated. So ciliated, and they are nothing but they are tall. And here also there is similar thing here, mirror image, and here there's nothing but the fibrous stroma with collagen fibers. Done. And here were the points as mentioned earlier. The stroma is scanty. Okay, that is an important point here. And moving ahead, we'll be looking at some other important topics, and we just have a few of them, and we will be finishing it. And yes, we have accomplished a lot today. And looking at colloid goiter, this is number colloid goiter, right? So here you can see scarring. So just draw it. Okay, so there's nothing but scarring can be seen, right? There can also be presence of micropapilla. There's presence of calcification that can be seen. Calcification. And also presence of hemorrhage. Yes, so in case of colloid goiter, we need to remember that there is hemorrhages and there's calcification. Two very important points. So now after this, we can also see chronic inflammation. Inflammation that can be seen, as well as there's a partial capsule that can be seen. Right? There's partial capsule. So there's also chronic inflammation. Yeah, I already mentioned it. So now just looking at some of the points. The colloid goiter, the most of the acini are distended to varying degrees. Some of them have ruptured and coalescent with each other, and the epithelial lining the acini is very much thinned out and is represented only by a row of round vesicular nuclei. Okay. And within the distended acini, there is marked accumulation of the colloid, which is homogeneous and acidophilic, staining pink. Okay, fine. And then between the lobules, there's band of fibrous tissue seen. Okay, and they contain capillaries, extra vesicated RBC, and occasional small round cells. Okay, so just highlighting, there is a presence of scarring. There's a presence of there's presence of hemorrhages, there's presence of calcification, there is presence of partial capsule is there. There's partial capsule. There's variable size follicles. Variable size follicles. Just drawing it again. So there is scarring seen, scarring, presence of micropapillae, there's calcification, there's hemorrhage, there is chronic inflammation. So there are three things that can be seen: calcification, hemorrhage, and chronic inflammation. Nothing but chronic inflammation is seen. And there's also the partial capsule that can be seen here. Done. So yes, this is nothing but what is it? Nodular or colloidal goiter. Yes. So we have finished that. Now we'll be talking about the famous one, that is nothing but the HT. Any guesses? HT is nothing but the Hashimoto thyroiditis. Right? So now looking at what is Hashimoto thyroiditis, firstly we'll have a slide, nothing but the, it looks like an L, right? So we'll have the lobular septa, or in case you want a H, we can make it an H, so there's no issue, right? It's H, it's easier to memorize. So lobular septa, right? Here important, there's presence of Hürthle cell, right? What is this? There's nothing but the Hürthle cell. And there's also presence of lymphoid cell infiltration. Yes. What is this? This is nothing but the lymphoid cell infiltration, right? Next, we also have the atrophic follicle. Nothing but the atrophic follicle that is present. So let's just recap what we have drawn. There's also the lymphoid follicle. Yes, let's just recap. So there's presence of the lymphoid follicle, there's presence of the lymphoid cell, there's lymphoid cell infiltration, there's presence of Hürthle cell, very important. And in between we drew an H, there's nothing but, or H, which is nothing but the lobular septa. And this is the atrophic follicle, this is the nothing but the lymphoid follicles. Okay, next moving on, we'll be looking at a famous characteristic of ground glass appearance. Can you guess which one it is? Yes, it is the PCT, papillary carcinoma of thyroid, right? So here we'll draw some. Okay, so this is just rough. So here we have ground glass appearance. This is nothing but tumor cells. And tumor cells have nothing but the ground glass appearance. Fine. The important point, ground glass appearance. And there's also presence of the Samoma bodies. Samoma bodies. Right? And there's presence of fibrovascular stalk. It's easy, right? So there's ground glass appearance. And what is this due to? It is nothing but due to the tumor cells. And there's presence of the Samoma bodies. Yes, Samoma bodies. Fine. And there's also presence of the fibrovascular stalk. Okay. So we have actually achieved a lot. So let's just quickly read through the point which about the PCT. Note the presence of the thyroid tissue at one end. Okay, fine. And then there's large papillary processes consisting of branches, vesicular stroma, covered with cuboidal epithelium projecting into cystic follicular spaces. Okay, and then the epithelial cells are uniform and there are few mitotic figures. Okay, and the nucleus has a characteristic appearance with a prominent nuclear membrane and clear central area that is nothing but a ground glass or often an eye appearance. Any eye appearance. Okay, so this ground glass or often eye appearance. Often eye appearance. Fine. Ground glass, often eye appearance. Fine. And there's also presence of Samoma bodies in the stroma. So PCT is really important because it has all the characteristic points, that is Samoma bodies. Yes. There's presence of fibrovascular stalk. there's presence of papillae. Fine. Now moving ahead, what we have to see is some important term. There are many, but I'm just picking a handful so that it doesn't, we don't have to make more time. So this is the, hopefully this is the last one. Is it the last one? Yes, hopefully yes, this is the last one I'll be talking about. So here this is the transitional cell carcinoma. Okay, so here looking at the transitional cell carcinoma, presence of stromal invasion, yes, and there's also presence of anaplastic tumor cells, I'm just writing it short. So this is nothing but the transitional cell carcinoma. Very easy. Stromal invasion, and there's anaplastic tumor cells that are present. So I will be revising again. So now let's just look at some cells which we need to know. Or do you want that, or I'll continue? Okay, so in case of, we'll be looking at anemia as well. So some important anemia diagrams, few diagrams, and then that's it. So in case of, one second, macrocytic anemia, we have microcytic anemia. Then we also have some diagrams like the anemia, that is the hereditary spherocytosis as well, and also the acute lymphoid, and all these diagrams. So I'll be quickly just small, it's a small topic, so I'll just draw it here. Okay, fine. So I'll just draw it in one page and finish it off. So there's macrocytic anemia, right? So there, as usual, you can have presence of neutrophil, right? And there can be presence of platelets. There are presence of macrolides, right? I'm not explaining much, believing all of us know a few points about it. Next, there's also small lymphocytes which can be present. Fine. So what have we seen? We have seen presence of neutrophils. There can be a few platelets as well. There's few macrocytes. There's small lymphocytes as well. Fine. Now looking at the same thing as microcytic hypochromic type anemia. So here looking at microcytic hypochromic anemia, there is presence of neutrophil again, and there's also presence of platelets. These are nothing but platelets. There's presence of target cell. There's pencil shaped cell. This is all microcytic hypochromic anemia. This is pencil shaped cell, and there's microcytic hypochromic RBC. Okay, since I've drawn it small, I will draw just the two diagrams again in a bigger fashion. Yes, so this is nothing but the macrocytes, right? And then we have LMN, right? LMNOP, correct? So macrocytes is done. So then LMN, so N for neutrophils, O for lymphocytes, small lymphocytes, LMNOP, P for platelets. So in case of macrocytic anemia, yes, some important points, important contents that are macrocytes, neutrophils, and platelets, as well as small lymphocyte. Okay, so it has been almost 1.5 hours, so it's good that you have been staying along. So looking at microcytic hypochromic anemia. So looking at microcytic hypochromic anemia, yes, so there is pencil shaped cells. Okay, so you can draw an arrow, and you can call it pencil, that is pencil shaped cell. There's presence of platelets as well. Platelets. There's presence of target cell. Target cell. There's presence of microcytic hyperchromic RBCs as mentioned in the heading, that is microcytic hyperchromic RBC. Yes, so there's presence of platelets, pencil shaped cells, and in case of pencil shaped cell, along with that comes the target cell as well. So there's target cell, and there's also the neutrophils, which is present in most neutrophils. Fine. Pencil shaped cell, there's target cell, there's neutrophil, and there is microcytic hyperchromic RBC as well. So now moving ahead, we'll be looking at the few important other ones, that will be AML. What is AML? That is nothing but, let me go through my notes. Where did I write that? Yes, I found it. So in case of we comparing, this will be AML. This will be very rough, and I'll just do it quick because we have already taken some time. So AML is nothing but acute myeloid myeloblastic leukemia. ALL is nothing but acute lymphoblastic leukemia. Okay, so I hope the full form is clear, so I won't be writing that again. So in case of acute, we'll have normocytic RBC. So acute, no matter what acute cases there are nothing but normocytic RBC. So both cases, what are we seeing? Normocytic RBCs. Fine. Okay, and then there are presence of myeloblast. Acute myeloblastic leukemia, right? This is nothing but myeloblastic blast. So we'll have some myeloblastic structures, myeloblast structure, right? And there's also presence of the myeloblast with rods. Correct? So these are nothing but myeloblast with presence of rods. Correct? So far so good, I believe so. And then here also there's normoblastic RBC, and there's present of lymphoblast. As mentioned, myeloblast is present there and lymphoblast is present here. So let's draw the lymphoblast. Yes. Next we'll be looking at CML and CLL. Again, CML or CLL, right? So this is chronic myeloid leukemia. So here we have a proper RBC. There's RBC like this. So whereas in that case we had a normocytic RBC, here we do not have a normocytic RBC. Fine. It's clear, right? So here we also have a neutrophil. Correct. And also a hyperpigmented neutrophil. Right. And then moving on with the CLL, that is nothing but the chronic myeloid leukemia. The CLL. Yes, in the CLL we'll be looking at the structure. Here there's RBC. There's presence of smudge cell as well. There's smudge cell. And there's also presence of small lymphocyte. Correct. So here we have seen in CML, we can see the hyperpigmented neutrophil, we can see the RBC, we can see the neutrophil. Yeah, the same neutrophil. So here we can see the presence of smudge cell. Smudge cell is a characteristic of CLL. Smudge cell as well as small lymphocytes can also be noted. Now quickly we'll just recap through everything we have done. So now thank you for being along throughout this video. Now we'll just go back and see keep, right? So great, we have almost finished. How many slides? We have finished 36 slides, And it's not just presenting the already that is written, but we have just written and presented about 40 slides. So I'm really happy with the progress. So here I'll just recap quickly. So let's from current, I'll just give a quick read through throughout the topics. So in case of this, I think I'll change the color, right? So how do I do that? Draw, right? This one. Okay. So which one? How is this? Will this change? This is rainbow. Wow, it's crazy. Okay, I'll draw that, and I think okay, this is going to be really good. I didn't notice this. Okay, so this is a nice feature. So let's go slideshow, start from start. Okay, so in case this is nothing but the recap of it. Hey, why is this? 1 second. Insert, design, draw. Yes, slideshow. Why is it happening like this? Okay, I think I'll continue with it being like this. Yes, I want this. Sparkle animation, yes. Yes, so pathology, slides, revision. Okay, I think something is, wait 1 second. Okay, slideshow. Okay, so pathology, I have no, wait, last try, otherwise I'll just leave it. Okay, at least any color will be fine. Slideshow. No, it's not happening, sorry. So now let's continue. So pathology is slide revision. So firstly we saw the granulation tissue. Granulation tissue has a V structure. This is nothing but the ulceration, and then we also saw, we clubbed it into two, that is the lymphocytes and macrophages, as well as the presence of other two cells, right? The foam cells. Is it the foam cells? No, the macrophages, lymphocytes, eosinophils, and the plasma cells. I repeat, plasma cells, eosinophils, and also the lymphocytes and macrophages. And we have seen the characteristic property of the fibroblastic cells. It has a cytoplasm as well as the central nuclei. And then moving ahead, we have the acute appendicitis. And acute appendicitis, we have a region of necrosis as well as the ulceration can be seen. And as told earlier, it's easier to remember, divide it into zones, that is mucosa, submucosa, muscularis externa, and the serosa. And the muscularis externa is divided into two parts, that is the circular as well as the longitudinal. Okay, hopefully it's clear. Now moving ahead, we have the tubercular lymphadenitis. Tubercular lymphadenitis, there is nothing but the capsule, and then you have an important point characteristic, that is nothing but the presence of the giant cells, and there's also presence of the lymphocytes. There's epithelioid as well as epithelial cells, as well as the giant cells. Okay, and there's areas of necrosis as well. So here there's a capsule, there's necrosis, there is a giant cell, and as well as the lymphocytes are present. Now moving ahead, we have the tuberculoid leprosy, and as told earlier, there are the presence of two L's, and these two L's indicates the presence of the Langerhans giant cells, which can also be present. So in case of what giant cell is present, it is nothing but the Langerhans giant cells. So yes, we have the Langerhans giant cells as presence of epithelioid cells surrounding it, and also the eroded epidermis that is present. And you can also indicate the presence of the caseous nerve and also the lymphocytes. So to go slow, I will repeat again. And there's presence of epithelioid cells, there's presence of Langerhans giant cells, there's eroded epidermis, as you see, there is Langerhans giant cells, epithelial cells, and the caseous nerve that can be found, as well as the lymphocytes. Moving ahead, we have the fatty liver. Fatty liver, what we have seen is that it is not disturbed, whereas we have seen another type of liver, right? And there, what we have seen is there is a disturbance. So here, in case of fatty liver, there is no such disturbance, and there is a central vein, there's macrovesicles, microvesicles, there's presence of fat cyst, okay? And the cells, if you see, it's like signet ring-shaped structures. So the nucleus is pushed to one hand, and the portal triad is nothing but the presence of an artery, the vein, as well as the bile duct. Moving ahead, we'll be looking at hyaline degeneration. As mentioned earlier, there's a small dot, that's nothing but the hyaline change, and surrounding the hyaline change there is a Wold pattern, Okay, and there's benign smooth muscles also, the smooth muscle, okay, the smooth muscle surrounding it, and there's presence of fibroblast. These are nothing but the fibroblast, right? Now moving ahead, we'll be looking at the spleen. Spleen is nothing but there's a presence of capsule, there's presence of fibrotic nodules, there's iron and calcium deposition. Fibrotic nodules with iron and calcium deposition is nothing but the gamma Gandhi bodies, okay, the GGB. There's nothing but the gamma Gandhi bodies. So in case of CVC spleen, we need to know there's presence of gamma Gandhi bodies, that is nothing but G, and B. So it's nothing but fibrotic nodules containing iron and calcium, and there's congested sinusoids. Okay, good enough. So let's go quick. So squamous papilloma is nothing but this HAP, hyperkeratosis, acanthosis, and papillomatosis. Okay, hyperkeratosis, acanthosis, and papillomatosis, and this intact basement membrane. And squamous cell carcinoma is nothing but there's a downward proliferation, a malignant squamous cells, and also the presence of the keratin pulse. This is important. There's presence of keratin pulse in case of squamous cell carcinoma. Pulse, right? This presence of keratin pulse as well as downward proliferation and malignant squamous cells. Now fibroadenoma, we know it's intracanalicula and pericanalicular. Intercanalicular. In pericanalicular, it is like a ring shaped and there is a duct, okay? And intracanalicular, there's a slit-like appearance, and it has a wavy appearance as well, wavy slit-like appearance. And this lipoma, very easy to identify, capsule as well as the mature adipocytes, and there is blood vessels as well. Now looking at neurofibroma, there's no fibers, and the nucleus is arranged in parallel fashion. There's also fibroblast that can be seen, and also presence of foam cells. So neurofibroma, F stands for foam cells. You can imagine like that, and it's easier to write. So there's presence of foam cells as well as no fiber. N is nothing but for no fiber. Fine. So now moving ahead, we have capillary hemangioma. Capillary hemangioma, there is plump endothelium. So cap is plump endothelium. Just imagine a cap with some plump. Okay, plump endothelium, right? Or you can imagine a plum cake, right? C, right, written on the side as design. So this is nothing but capillary hemangioma. It is plump endothelium, right? And there's no inflammatory reaction that is seen. This is important. Moving ahead, cavernous. Cavernous, there's flat endothelium. There's a cavernous space that is seen. And there can also be normal liver. See, there is flat endothelium, right? Flattened endothelium. And there's also cavernous space, correct? And there's also the normal liver tissue that is present. Good enough. Now moving ahead, schwannoma. I told you there is there's a super A that I drew. So antennae A particle is inside, antennae B particle is outside, and this palisaded nuclei, Verroque bodies are present. Now moving ahead, we have the basal cell carcinoma. There is downward proliferation, as we saw. There is horn pulse, presence of tumor cells. There is solid pattern. Just remember these words: solid pattern and palisade arrangement are seen. This is in case of basal cell carcinoma. So there is solid pattern as well as basal palisade arrangement. So solid pattern as well as palisade arrangement. Done. Now going ahead, we have the adenocarcinoma. Okay, adenocarcinoma colon. So there's malignant cells as well as pule of mucin. This is nothing but the lymph node. Yes. Here we have the capsule. There is subcapsular lining, sinus, and there's malignant cells as well as presence of the lymph node. Moving ahead, there is the benign teratoma ovary. Here there is cartilage. There is I think I've drawn it again. No, I've not. Okay, so there's presence of cartilage as mentioned. There's presence of smooth muscles. Here there's presence of adipocytes. There's presence of gland. Here adipocytes, gland, adipocytes. There's presence of cartilage, and there's presence of smooth muscles as well. Smooth muscle. Okay. So moving ahead, there's atheroma. So this we had a lot of labelings here. So there was presence of plasma cell. There's presence of lymphocyte. There was presence of, this was easy, right, to memorize. I have drawn it again. Yes, this mountain and this is nothing but the disturbed elastic lamina, and this top thing is nothing but the adventitious, what is it? It is nothing but the necrotic debris. This is the foam cell, this is the plasma cell, and this is vasa vasorum that is present in the bottom, and proliferating smooth cells. Let me repeat again: foam cells, plasma cells, proliferating smooth cells, there's presence of elastic lamina, and this is nothing but the necrotic debris. Moving ahead, there's gastric ulcer. Gastric ulcer, we know there's a wavy pattern, there's intact mucosa, there's necrotic debris as well, and there's presence of granulation. We know that there's a presence of many zones. There's granulation zone, there's cicatrization zone. So zone of granulation, zone of cicatrization, and the intact mucosa and the necrosis is seen. Moving ahead, we have the cirrhosis of the liver. Cirrhosis of the liver, there's uniform micronodule. There's there's also the fibrous septa that is present. And here what I've seen is there's a distortion of the liver cells architecture. And here, as we know, there's a fibrous septa, it divides it into lobes, and there's fatty change as well. Moving ahead, we have the renal cell carcinoma. They have presence of clear cells, they have glandular pattern as well as solid pattern. The uniform tubular cells, and what we have seen here is there can be presence of hemorrhage as well as necrosis. That is in case of the renal cell carcinoma. Now moving ahead, we have the secretory endometrium. Secretory endometrium is there are tortuous glands and lining the glandular epithelium. This is fine, and there is there's also glycogen granules that can be present. Moving ahead, we have the cystadenoma ovary. So this is also a simple diagram. So there's mucinous as well as serous. Serous, there is huge columnar cells, and in between there is fibrous stroma with collagen fibers. Here also there is fibrous stroma, and here there is mucinar space that can be seen. Okay, so here talking about this mucinous, I have already written. There's columnar cells, there's fibrous septa, and there's mucinous material that is present in the between. And then moving ahead, I have just drawn it again. There's columnar epithelium, fibrous stroma, mucinous, and then there's fibrous stroma and collagen fiber, fibers. And then moving ahead with collagen fibers, colloid goiter, there's scarring that is present, there's micropapillae that's present, there's hemorrhage, calcification. That is an important aspect of colloid goiter. There's hemorrhage as well as calcification that can be seen. Is an important point that can be noted. And there's chronic inflammation also seen. So there's hemorrhage, there's calcification as well as chronic inflammation, right? So now looking at the nodular goiter, this is nothing but the nodular goiter. So there is micropapillae that is present, there's also calcification, there's hemorrhage also, and there's partial capsule that is present. So in colloid goiter, there's partial capsule. Just make a note, there's partial capsule, not complete capsule. There's partial capsule. And then moving ahead, there's hemorrhage as well as calcification. Now moving ahead, we have Hashimoto thyroiditis. There's lymphoid infiltration. We draw a slide like H. That's nothing but the presence of hurdle cell. So there's a H and the H. There's nothing but the hurdle cell. So this is nothing but the lobular septa. This is lobular septa. And then there's also presence of the lymphoid cell infiltration. Yes, infiltration. And there's atrophic follicle. Now moving ahead, we have the PCT. It's nothing but the papillary carcinoma thyroid. It has the ground glass appearance as mentioned earlier. And there's also presence of Samoma bodies. Yeah, ground glass appearance. Okay, ground glass appearance as well as Samoma bodies. Very important points, Samoma bodies. And moving ahead, we have the transitional cell carcinoma, easy. There's a stromal invasion as well as the anaplastic tumor cells present. Now looking at the macrocytic anemia, we have drawn the macrocytes, the neutrophils, LMN, that is macrocytes, there's neutrophils as well as the lymphocytes and platelets. And the microcytic hypochromic anemia, that is we have the pencil shaped cells along with the target cells, yeah, pencil shaped cells and the target cells, and also the platelets that are present in between. There's also the neutrophils that can be present. Then moving ahead, we have the AML. Let me recap again. So macrocytes, neutrophils in case of this thing, macrophage, neutrophils, as well as platelets and small lymphocytes. In microcytic hypochromic, there's presence of target cell, this pencil shaped cell, yeah, this is microcyte. So you can imagine of a micro pencil, so microcyte, yeah, pencil shaped cell, target cells and platelets, yeah. Now we'll be looking at AML and ALL. So in case of acute, there's basically just normocytic cells, yeah, normocytic RBC cells. There's presence of myeloblast with or rods as well, okay. And also the lymphocytes are present, lymphoblast. So there's blast, so myeloblast and lymphoblast. Fine. So now CML and AML, CLL. So there's hyperpigmented neutrophils present here. The small lymphocytes as well as smudge cells present in CLL. So now I would like to thank all of you for watching this. It has been a 2-hour journey. So I have been explaining for 2 hours. So thank you really for watching and helping me revise my contents as well. So I could continue with this 2 hours pace only because I had revised this already multiple times. So in case you have revised already, you would really enjoy watching this again and again. And in case you like it, please give a thumbs up so that I can see that many people are actually watching this. And in case you haven't subscribed, please do subscribe so that you can catch up with the latest updates. No problem, if you are already in the PPM group, I will be updating it on WhatsApp as well and regular updates. So thank you. It has been a great journey talking and explaining for 2 hours continuously. So thanks for watching, and please don't forget to give a thumbs up. So thanks for watching. Thank you.